Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, friends and colleagues. On behalf of Emirates Diabetes Society Board, I would like to welcome you all to our Young Leader Forum. And as the name indicates, it meant for the rising star who pursue their career in the field of endocrinology and diabetes. And it is a practical workshop which will cover practical points, which include the diagnosis and management. We did test the Young Leader Forum program last year in 2019 on a small scale, and we found it to be one of the very successful and rewarding meeting. So now, as we are all turning to a virtual meeting, we wanted to pursue this as further in order to cover, broader scales of colleague and rising star in the field of the endocrinology and diabetes. And tonight we're going to have an excellent speaker in the field of endocrinology and diabetes, who's going to be, introduced shortly by my colleague. I would like to, encourage all of you to come forward. If you have any interesting case that you want to share with us, then we will be more than happy to accommodate this. And I would like now to leave the mic to one of our rising star, Dr. Budoor Al-Imadi, who's a specialist endocrinologist at Dubai Hospital, Dubai Health Authority. Budoor had completed her board of internal medicine and also the Saudi board of endocrinology and metabolism from King Faisal Specialty Hospital, as well as specialty endocrine certificate from Royal College of Physicians, and also she is certified ICNO certificate, which is in the ultrasound performing from the American Association of Clinical Endocrinologists. Budoor is very active member of the endocrine department team at Dubai Hospital in Dubai Health Authority, and since she finished and completed her fellowship program from Saudi Arabia, she was responsible for all the academic activity taking place in the hospital. And Budoor is one of the founder member of the Young Leader Forum who believed in it and pursued the program and took all the responsibility with all the speaker that you're going to hear them tonight to take this further. And she's determined with her colleague to make this one of the successful meeting. And without further delay, I wish you all the best you are the leads of our future endocrinology in United Arab Emirates. And without further delay, I hand the mic to Dr. Budoor to introduce the speaker. Budoor, the mic is yours.
Thank you, Dr. Fathiya, for your kind introduction. Assalamu alaikum jami'an. Good evening all, colleagues and friends. Welcome to our first online webinar, Young Leader Forum. Our session today is about calcium. It's a practical guide, guide for the diagnosis and management of calcium and bone disorders. Prior to starting this session, first I would like to let you know that this is a 1.5 CME accredited academic activity by Dubai Health Authority. Following the session, you will be receiving a survey and a quiz. Kindly fill the quiz and answer the survey. Post that, you will be receiving your certificate in 7 days. And during the session, if you have any questions, you can always post your questions during the seminars in the Q&A box, which will be discussed later at the discussion session with the whole panelists. Finally, I would like to thank our sponsor tonight for our academic activity, Servier. And now, with no further delay, I will start with our first presenter, Dr. Asma Al-Jabri. Dr. Asma Al-Jabri is going to present today an update on osteoporosis, diagnosis and management. Dr. Asma is a consultant endocrine at Tawam Hospital. She has completed her clinical and research endocrine fellowship at Division of Diabetes and Endocrine at Vanderbilt University in US. Her field of interest in endocrine is osteoporosis, bone metabolism, obesity, and lipid disorders. I'll hand the mic to Dr. Asma. Dr. Asma, kindly unmute your mic and share your video with the audience.
Thank you, Dr. Badur, for the kind introduction, and I would like to thank EDS for inviting me tonight to speak about diagnosis and management of osteoporosis. There is lots of things to be covered in 30 minutes, so without any further ado, I would like to proceed with my presentation. I don't have any disclosure. My learning objectives for tonight is to be able to assess risk factors for osteoporosis and apply evidence-based screening recommendation, utilize the tools to facilitate improving the assessment and care being provided to patients with osteoporosis, and develop strategies to improve the treatment for patients with osteoporosis. We'll start with definition of osteoporosis as it's mentioned in textbook. Osteoporosis is a skeletal disorder characterized by a compromised bone strength predisposing to an increased risk of a fracture. And if you can see here, this is the normal bone, and this is a picture of osteoporotic bone. As you see, there is a compromised bone density. The bone density in osteoporotic bone is less than normal bone, and the bone quality is poor comparing to the normal bone. In clinical practice, we're defining osteoporosis based on the T-score of BMD of the patient. And WHO classification of BMD based on the T-score defining the patient as having osteoporosis if their T-score is minus 2.5 or lower, and severe osteoporosis if the patient T-score is minus 2.5 or lower with a history of fragility fracture. There is a caveat with WHO classification. So patients with T-score lower than minus 2.5 could be having other diseases other than osteoporosis, and example of this, osteomalacia or patient with CKD MVD. And patients with might have osteoporosis even though their T-score is higher than minus 2.5. And example of this, patients with osteopenia and history of fragility fracture. Or when we're calculating their FRAX score, they're having high FRAX score. So basically, it's very important to assess patient risk of a fracture when determining patients if the patient is having osteoporosis or not. That's why with this caveat in WHO classification of osteoporosis, in 2020, ACE and ACE diagnostic criteria for osteoporosis developed different criteria for the definition. So we're having 4 categories of patients with osteoporosis. If the patient is having T-score minus 2.5 or low, or the patient is having low trauma spine or hip fracture, regardless of their BMD, or T-score between minus 2 and minus 2.5 with a history of fragility fracture, or the patient with also T-score between minus 1 to minus 2.5 and having a high FRAX score. So we defined what we meant by osteoporosis. Now we need to know what are the tools to diagnose patients with osteoporosis. So we're having mainly 3 tools to help us in diagnosing our patient, doing DEXA scan, or taking more detailed history of the patient's clinical history, especially if the patient is having a history of fragility fractures, or using fracture risk algorithms like FRAX. Who should be screened with DEXA scan? So according to the National Osteoporosis Foundation guidelines, all women 65 or older, or men 70 years or older, postmenopausal women and men between age 50 to 69 with a high risk fracture risk factors, or adults who have a fracture after age 50, or adults with the conditions or taking medications that might associated with a low bone or bone loss. If you're having a patient with a T-score minus 1 or lower with one of the following criteria: women age 70 and above, or men age 80 and above, or history of height loss 1.5 inch or higher, self-reported but undocumented vertebral fracture, or history of glucocorticoid therapy 5 milligram of steroids for 3 months or more, we're recommending to do vertebral fracture assessment by using DEXA scan. So it's either to do it through a regular X-ray or to do it by using the DEXA scan. And according to ISCD recommendation, better to do it through the DEXA scan since the risk of radiation exposure is less than the conventional X-ray. X-ray, and it's cheaper to do it through the DEXA scan. The other tool to diagnose patient with osteoporosis is using the FRAX score, which is algorithm, give us the 10-year probability of a fracture, calculating the risk of major osteoporotic fracture or hip fracture. And FRAX is a model obtained from population-based cohort. And when you're using the FRAX, you should, the calculation tool, you should use the country-based threshold. For example, in the UAE, you should use the Middle East Africa and use Abu Dhabi. If you're taking care of an Emirati patient or you're taking of another nationality, you should use the country-specific threshold. So FRAX is asking about certain risk factors of the patients, like age, sex of the patient, weight, height, previous fracture. And I would like to bring your attention that previous fracture only for long bone should be taken into consideration, but nor hands or feet or skull should be taken as a fracture risk when you're calculating the FRAX. Parent fractured hip only if it occurred when they're less than 80 years of age. Current smoking, yes or no, regardless of the amount of smoking, glucocorticoid use, rheumatoid arthritis, secondary osteoporosis, causes, alcohol 3 units or more per day. And if you're going to use the DEXA scan, the BMD with the FRAX, that will be additive to the FRAX. You can use the FRAX with BMD or without BMD. So FRAX has its own benefits and limitations. The benefits drive 10 years probability of a clinical event from measurable parameter, internationally recognized and validated based on data from multiple cohorts, easily accessible on internet or DEXA software, help identify patients who need treatment, and can be used to reassure low-risk patients. The limitation of a FRAX, it's not valid to monitor patients on treatment. It's only taken into consideration femoral neck BMD. Other than that, it's not considered in the FRAX. And risk is always yes or no. And there is no consideration of the dose. For example, how many cigarettes per day, or what is the dose of glucocorticoid or alcohol. Not all risk factors are included, especially a risk of fall is not included in the FRAX, and clinical judgment is always required. And do those patients who's having high FRAX score will benefit from treatment is still unknown. As we're in clinical practice see many patients with diabetes, around 20% of our patients are diabetic, we see that FRAX score is really underestimated the risk of a fracture in diabetic patients. If you can see here, this is the risk of fracture of non-diabetic, and this is the risk of a fracture in diabetic patients. So if we're using the FRAX and we're not logging diabetes as a risk factor, the FRAX will be lower than the reality. So the bone expert worldwide suggested that we can tweak the FRAX to have a better estimation of for the fracture risk in diabetic patients. For example, if you're going to use the BMD, you should lower T-score by -5. Or if you're going to use the BMD with you're going to use the FRAX without BMD, you can take rheumatoid arthritis risk as the patient is having diabetes if the patient is not having rheumatoid arthritis. But if your patient is having rheumatoid arthritis and diabetes at the same time, you should take other secondary causes as diabetes. It was found from clinical studies that TZDs and canagliflozin, medication used for treatment of diabetes, is having a negative effect on BMD, and one expert suggesting that we should take yes for glucocorticoid whenever the patient's on TZD or canagliflozin. The other tool can help us in better diagnosing the patients with osteoporosis whenever we're using the FRAX score is using the TBS. TBS is a software which can be installed in DEXA machine. It's going to give us a better idea about the trabecular bone. For example, if we're looking at this image, this is the BMD for two patients, almost equal. But when we calculated the TBS for those patients, this patient TBS is 1.459, when the patient trabecular bone is well intact. And this patient who's having almost similar BMD, the TBS is lower and he's having altered trabecular score bone. So his score, when it's going to be added to in FRAX, we will have a better FRAX assessment of the patient risk to have a fracture. The last thing, whenever we encounter with the patients, when evaluating patients for the risk of diabetes, we should take a detailed history about secondary causes for osteoporosis. And we know that there is many secondary endocrine, hematological, rheumatological, neurological diseases can affect the patient and increase the risk to have diabetes other than only aging. So now we know what we meant by osteoporosis. We went through the tools, how to diagnose the patient. Now we need to know whom to treat. So according to the National Osteoporosis Foundation guidelines, it was very easy before that all women age 65 or men 70 and above, with we should do the DEXA, FDT score minus 2.5 and lower, or with the hip or vertebral fracture, we should consider candidate for treatment. If the T-score is an osteopenia range, -1 to -2.5, we'll do the FRAX. If the FRAX is above than 3 for hip or 20 for major osteoporotic fracture, patients will be candidate for a treatment. In 2020, Endocrine Society, ACE, and ACE came with a new concept, that is the risk stratification. So they stratified the risk of patients to have diabetes, and they divided the patients into low risk, moderate, high, and very high risk. So almost low, moderate, high, both the Endocrine Society and ACE agreed on the definition, but with the high risk, Endocrine Society and ACE have different criteria to diagnose the patients. And that risk of stratification will have an implications on treatment, and we will see it later on. So patients with very high risk means that the patient is an Endocrine Society T-score is -2.5 or lower, fracture, or patient is having multiple vertebral fracture or severe vertebral fracture means that patient has more than 40% of vertebral height loss. Based on ACE, the patients with less than -3, T-score, fracture in the last 12 months, fracture on treatment, fracture on harmful drugs, multiple fracture or high for risk for patients, or FRAX score very high, consider MOF more than 30 or hip fracture more than 4.5. So there is a list of medications already approved by FDA for treatment of osteoporosis, starting from estrogen, which was approved in 85, then, for example, alendronate 95, teriparatide in 2000, zoledronic acid in 2007, denosumab in 2010, and abeloparatide 2017, and the new baby on the block 2019, romosozumab. So these medications divided in 3 classes. The class 1 inhibit the bone resorption, and we call them anti-resorptive. Bisphosphonate under this class, denosumab, SERM, calcitonin, and estrogen. Medication considered to stimulate the bone formation, like teriparatide and abeloparatide, and medication with dual effect, both anti-resorptive and anabolic, like romosozumab. Each of these medications has its own pros and cons. For example, oral bisphosphonate is inexpensive, but it has also GI side effect, and we should be avoided when the patient is having low GFR. Zoledronic acid, very long dosing interval. Post-hip fracture data is very good, but it has risk of acute phase reaction. You need to bring the patients to the hospital to have an IV dose, and should be avoided with a low GFR. Denosumab, good and long dosing interval every 6 months, greater BMD increase when you're giving to your patient. It's only sub-Q injection, but there is FDA list of side effects like back pain and high cholesterol. Raloxifene is not a bisphosphonate. It's good and decreases breast cancer risk, but you should be aware that it has a risk of VTE, hot flashes, and we don't have a proven hip fracture decrease with a SERM. Teriparatide, abeloparatide, romosozumab, they all anabolic medication. Whenever you're going to start it, you should be aware that the sequence matters with these medications. The cons of each medication differs from the other. For example, the cost is high with all these medication. Teriparatide, abeloparatide daily injection, rat osteosarcoma with teriparatide and abeloparatide. Teriparatide need refrigeration, but abeloparatide doesn't need refrigeration. Romosozumab, monthly injection may increase the risk of cardiovascular, but there is no risk of osteosarcoma. So current guidelines recommending that those patients should be started on bisphosphonate as first line of treatment for most patients with osteoporosis. Denosumab is the second line treatment if bisphosphonate is not tolerated. or unsuitable and anabolic or bone building medication should be considered with the very high risk patients. So why current recommendations are suboptimal for patients with very high risk? As I mentioned, Endocrine Society and ACE recommending anabolic to be started as the first line treatment for those kind of patients, because oral bisphosphonate is suboptimal in reducing non-vertebral spine and hip fracture, has a modest effect on BMD and has poor adherence, require years of treatment to increase BMD substantially, and use is recommended to be re-evaluated 3 to 4 to 5 years after that. Might be stopped due to the fear of rare side effects like atypical femoral fracture or osteonecrosis of the jaw. So whenever we're deciding the treatment, individualizing treatment decisions is very important. Choosing the right drug, considering all available clinical data. Going back to the risk stratification, I told you that it's going to have implications on treatment. For example, low risk doesn't need any treatment, moderate doesn't need a treatment, or based on your clinical judgment, you might start with bisphosphonate orally. High risk patients, bisphosphonate oral or IV, denosumab, SERM, very high risk. Both Endocrine Society and ACE agreed that anabolic, bisphosphonate, denosumab should be started. Should be started with anabolic followed by anti-resorptive to maintain the effect of anabolic medication. We're coming to the new notion of coming these days that we need to treat to target. The target is to decrease the risk of a fracture on those patients, not only to achieve the response with increasing the BMD. So treatment should be selected according to the likelihood of achieving an acceptable level of a fracture risk. A patient may respond to therapy, yet still have an unacceptably high risk of a fracture. So response to therapy is essential, but not necessarily sufficient in achieving an acceptable level of risk of a fracture. There have been many studies published in this term showing that all these medication is having a good efficacy and increasing the BMD and decreasing to some degree the risk of a fracture. Even we're talking about HRT, SERM, anti-resorptive, denosumab, there are many trials have been done. If we're talking about anabolic, there is decrease of risk of a fracture by 65% after 1 year, then 53% by 2 years. There is a study comparing eplerenone with teriparatide, more than 80% reduction in risk of fracture. Eplerenone was even better than teriparatide in this term. Talking about denosumab, romosozumab showed that it decreased the incidence of a new vertebral fracture by almost 73% after 1 year of a treatment. And when it was followed by denosumab, that risk reduction continued at the end of the 2 years to 75%. So efficacy of onset of action with highest potency anti-resorptive is important. Vertebral fracture risk reduction was 60 to 70% within the 12 months for vertebral fracture. For non-vertebral fracture risk reduction was almost 20 to 25% seen at 3 to 6 months. Efficacy of onset of action for anabolic, as I said, at around 19 months with teriparatide, risk of reduction was 65. At the end of the 2 years, reduction was 53. And for romosozumab, we've said that after 1 year of a treatment, reduction was almost 73, continued after continuing with the anti-resorptive to 75%. Again, this is showing the efficacy of anabolic medication when it was started compared to anti-resorptive in vivo study, comparing teriparatide with risedronate, which showed that anabolic is much higher in risk reduction of fracture. So take-home message in treatment: start a treatment with medication that is likely to achieve an acceptable level of a fracture risk. If you remember that when I talked about ACE guidelines for patients with very high risk, they mentioned that a risk of a fracture within the last 12 months, putting the patients at a high risk. Why? Because they found that the high imminent risk of second fracture within the first 2 years of index fracture, 60% of a fracture after hip fracture occurred within the first 2 years of a fracture. and 42% of a fracture after vertebral fracture occurred within the first 2 years. And for sure, it is also, again, age dependent. So that make now discussing all these things, going back to the importance of starting anabolic for those patients with very high risk, and giving us an idea how important to go with our sequence of a treatment. So if you remember, whenever I mentioned anabolic, I was talking about the sequence matters, and we will know during the next few slides why. Anabolic therapy is superior to anti-resorptive for very high-risk patients, and that was evidenced from 4 head-to-head study, GEO studying the teriparatide superior to alendronate. For severe postmenopausal osteoporosis, teriparatide was superior to risedronate, and for, again, severe postmenopausal romosozumab was superior to alendronate and with in vivo study, teriparatide proved to be superior to risedronate. So why we're considering anabolic first for very high-risk patients? Because data obtained from these 4 randomized controlled trials proved that they're superior, fast-acting and protection for the bone within the 12 to 18 months of a treatment, and restoring degrading bone microarchitecture with anabolic first, then we will maintain it with a starting anti-resorptive. And if we're starting anti-resorptive followed by anabolic, there will be attenuation of the effect of anabolic, which was seen in data switch study. So data switch study was studying denosumab with anabolic teriparatide. And if you can see here, when the patient was giving denosumab, then followed by teriparatide, BMD dropped even to the lower than the baseline BMD. While when the patient was taking teriparatide followed by denosumab, continued to increase in BMD, and the greater in BMD was when we combined both medication, denosumab and anabolic. We talked about the foundation effect with romosozumab followed by denosumab, the 1 year of romo followed by denosumab, 1 year of romo here followed by denosumab gives us as 7 years of continued denosumab, if you see here. So this is what we call the foundation effect. Whatever bond was rebuilt during the first year continued with the denosumab, and we were able to achieve the study were able to achieve to show that it's able to achieve the highest BMD within 2 years. Whenever you're switching from denosumab, which is anti-resorptive, to another to zoledronic acid, there was no much difference on the BMD. So just to summarize the sequential and combination therapy, if you're switching from anti-resorptive to anabolic, there is delay or attenuation of the anabolic effect, decreased BMD with whenever teriparatide was given after denosumab. If you're combining anti-resorptive with anabolic, teriparatide and denosumab, we saw that the greater BMD increase. Teriparatide and zoledronic acid showed that better BMD at head, but not significant at the spine and non-vertebral. Teriparatide and raloxifene, better BMD gain. Whenever you're switching from anabolic to anti-resorptive, you're going to maintain whatever you built during the anabolic, and that will help for more gain in BMD. Anti-resorptive followed by anti-resorptive, greater BMD effect with more robust anti-resorptive, especially whenever denosumab was given after bisphosphonate. Whenever you're combining both, there will be only slightly additive effect on BMD. So we know how to screen our patients, we diagnose our patient, started their treatment, how to monitor your patients. So monitoring patients, you need to monitor your patients by looking at their incidence of a fracture during the treatment, BMD change during the treatment, and change in bone turnover marker. Combination between BMD and bone turnover marker is going to improve identification of women at higher risk of a fracture. How to monitor your patient with DEXA, do DEXA scan 1 to 2 years during the treatment. Don't overestimate the change. Be happy whenever BMD is stable or increasing. You might notice that some of your patients lose BMD on treatment. You need to check the patient's compliance, drug pharmacokinetics, and underlying disorders that was missed in the initial evaluation of your patients. Patients on treatment whose BMD remained low at a higher risk of a fracture and may benefit from longer treatment. When and how to use bone turnover marker, which one to use. P1MP is a bone formation marker. CTX and NTX are bone resorption markers, and if your patient is having CKD, you should use bone alkaline phosphatase. When to use it, if your patient is having osteoporosis and you need to follow up your patients, and I advise always to look at least significant change if you're having more than one reading. Osteoporosis is a lifelong disease. And now you treat your patients, you're monitoring your patients, and you might ask me for how long you need to treat your patients. And I want to tell you that the patient, if the patient is having osteoporosis, even when you're treating, is still having osteoporosis. And there is a nice article published in Journal of Bone and Mineral Research. The title was Treated Osteoporosis is Still Osteoporosis. As if when you're treating your diabetic patients, when you're treating diabetic patients, is still a diabetic patient. So you're not going to stop the patients when their hemoglobin A1C is improving. So then you might ask me, what about the drug holiday? So when we should consider discontinuing therapy for patients with osteoporosis. So you should consider it based on 3 main points: treatment duration dependent adverse effect, weaning of a treatment efficacy with long-term treatment, and persistent of a treatment benefit upon stopping the treatment therapy. So if you look at these, you will find only bisphosphonate fit all these criteria. So FDA had a statement about the drug holiday. There are no substantial data available to inform decisions regarding initiation or duration of a drug holiday. So then you tell me when I should stop the treatment. There is also a nice article in Journal of Bone Mineral Research about managing osteoporosis in patients on long-term bisphosphonate treatment. And they're talking about if your patients completed 5 years on bisphosphonate oral or IV bisphosphonate 3 years, the patient had history of hip fracture or osteoporotic fracture before or during the therapy, then the patient should not have drug holiday, continued in treatment. If your patient didn't have fracture before or after, but their BMD is very low, -2.5 or lower, or the patient frax is very high, then patients also should not stop and continue in treatment. So no fracture before or after, BMD is higher than -2.5, frax is lower than 20 for major osteoporotic or 3, then patients might be considered for drug holiday. So I'm coming to the end of my presentation. Just a summary: osteoporosis is a decreased bone strength predisposing to an increased risk of a fracture. Why should you care? Because it's common, significant, cost and morbidity and mortality. Home to test and how DICSA for all women by age 65 and men by age 70. Higher risk here. FRAX is useful tool. Home to treat and how individuals at high risk of a fracture. Approved agents are safe and effective. Treatment decisions must be individualized. By this, I'm coming to the end of my presentation. Thanks for your attention. Mic back to Dr. Abdur. The question will be answered in Q&A session.
Thank you, Dr. Asma. That was a very well structured presentation and very informative talk. Just to remind our participants, we have so far 443 participants. We are very thankful for them to be part of our presentation today. If you have any questions for Dr. Asma or any of the presenters, you can post your questions during the session in the Q&A box, and later it will be addressed to the panelists. So we move to our second presenter. Our second presenter is Dr. Araya Al-Mazroui. Dr. Araya Al-Mazroui is going to present a case, hypercalcemia in a young man. Dr. Araya is a consultant endocrine at Tawam Hospital. She has finished her fellowship training in diabetes and endocrine at Imperial College in UK, and she's a graduate of Harvard Medical School Global Clinical Research Training Center. And she's involved in academic teaching for both under and postgraduates. The mic is yours, Dr. Araya. Kindly unmute your mic and share your video with the attendees.
Thank you, Badur, for the kind introduction. And thanks for giving me the chance to participate in today's event. And without further delay, I will start my presentation. So today my talk is about hypercalcemia in a young man, and the objective of the talk will be to have a brief overview of PTH calcium homeostasis, and then through a case presentation, I will touch base on approach to hypercalcemia and the differential diagnosis, and then we will have a look on the metabolic pathway for vitamin D, and hopefully we'll expand knowledge of a new differential diagnosis in hypercalcemia and how to manage. So in brief, the main contributor factor that control PTH secretion in our body is extracellular ionized calcium, as well as the active vitamin D125. If there is a rise in extracellular ionized calcium through stimulation of Caser receptor on the cell of parathyroid chief cell, it will lead to suppression of PTH expression as well as excretion. On the other hand, increase on the active form of vitamin D will lead as well to suppression of PTH expression through vitamin D receptor. Other controller of parathyroid hormone synthesis and secretion include FGF23 and serum phosphate. This figure shows you the relationship between serum total calcium and serum parathyroid hormone in normal status presented by or highlighted by the white box, as well as in different various disease state. In the normal status, any small change in total calcium will be associated with a higher magnitude in serum PTH in order to make sure that the calcium lies within the normal range. In patients who have hypopara, the PTH will be low as well as the calcium. In patients who have primary hyperpara, both PTH and calcium will be elevated. And in patients who have non-PTH related hypercalcemia, like hypercalcemia of malignancy, the PTH will be low while the calcium will be elevated. Now I will start with the case. This is a 33-year-old man who was referred to the endocrine clinic from the urology clinic with a 4-millimeter kidney stone, hypercalcemia, and hypercalciuria. He had mild fatigue, and this is his only symptom, and no other hypercalcemic or concerning symptoms. He was not on any medication that could contribute to hypercalcemia, specifically thiazide or lithium, and he was not on any supplements, including vitamin D and calcium. He had a strong positive family history of multiple family members with kidney stones, and his grandmother had been noted to have hypercalcemia in the past, but he is not aware of any further details. There was significant consanguinity in his family, and his examination was unremarkable, including normal vital signs and blood pressure. So when you approach a patient with hypercalcemia in a busy clinic, you need to have a focused history, focused exam. Your history should focus on hypercalcemia-related symptoms and symptoms that could direct you to underlying etiology, as well as a detailed history of medication and supplements, especially over-the-counter, as well as family history of hypercalcemia or previous parathyroid surgery or any other associated conditions or tumors. And on examination, you need to focus on the status of the patient, especially dehydration status, blood pressure, which could be related to severe hypercalcemia, as well as symptoms that suggest underlying etiology, like weight loss, for example, and cachexia in patient with malignancy, as well as, for example, chest examination in case of sarcoidosis and TB and so on. Also important point is to review the patient chart and see if the patient have any previous calcium measurement because chronic hypercalcemia may be to indicate a benign etiology, while sudden onset or a new onset severe hypercalcemia could be associated with malignancy. Also, you need to assess the severity and the degree of hypercalcemia and whether it is associated with acute kidney injury and needs admission or not. Now, this slide shows you the clinical manifestation of hypercalcemia, where multiple systems are involved, including renal, gastrointestinal, musculoskeletal, neurologic, and cardiovascular. And I just want to highlight here that renal manifestation could include, apart from diabetes insipidus, nephrogenic diabetes insipidus, it could include nephrolithiasis and nephrocalcinosis. Now, this slide just to remind you, when you take the history, to ask about other associated condition or tumor that could direct you to possible underlying genetic cause for sporadic or for syndromatic primary hyperpara. For example, pituitary tumors or neuroendocrine tumor in case of MIN1, or fibrosis jaw tumor or uterine tumor in case of hyperpara jaw tumor syndrome, or 2A. So when you encounter a patient with hypercalcemia, you need to confirm the diagnosis or the level. So if you have two readings with elevated calcium, then you need to know that we have three types of measurement. Most of the center will use total calcium, and in healthy individual, the assumption is that total calcium concentration accurately reflect the ionized calcium. However, this may not be true in case there was abnormal protein, like for example, in patient with hypoalbuminemia or hyperalbuminemia, or in patient with a plasma cell disorder like multiple myeloma, or in case of disturbance in acid-base balance. And therefore, most of the lab provide as well corrected total calcium. And there have been different formulas in which the most common one used is shown. However, also corrected total calcium may not reflect truly the ionized calcium in a critically ill surgical patient or renal failure or hemodialysis patient or very elderly hospitalized patient. And therefore, sometimes you will need to have ionized calcium measurement, especially in multiple myeloma or in patients that have been listed before. However, ionized calcium need rapid analysis in an anaerobic sample and also need to be placed in ice to counter various causes of pH alteration. Though there are some centers that use ionized calcium in all reported calcium level. However, it is not widely used because of these conditions. After confirming hypercalcemia, the next step is to measure PTH. And parathyroid hormone nowadays is measured through a sandwich assay or immunometric assay, which is second or third generation, and both of them are fine to be used. After you measure the PTH, if the patient have mid-upper normal elevation in their parathyroid hormone, or it is above the upper limit, then in patient with normal renal function, you will have two big differential, which is primary hyperpara and familial hypocalciuric hypercalcemia. And in order to differentiate these two, apart from the calcium level, you will need 24-hour urine calcium collection. In patients who have asymptomatic primary hyperpara or mild primary hyperpara, you will see this table with the symptoms is not really helpful in differentiating the two conditions. However, in general, in patients who have severe hypercalcemia with elevated PTH, it is most likely to be primary hyperpara rather than FHH. Also, family history of hypercalcemia, though it is most likely in FHH, nowadays we know that almost 10% of patients with primary hyperpara will harbor a gene defect in one of the 11 genes associated with primary hyperpara. Therefore, people suggest to use calcium creatinine clearance ratio. And with using the cutoff less than 0.01, you have a around sensitivity of 80% and a specificity of 88% for diagnosing FHH. However, you need to remember that there are certain conditions where patients with primary hyperpara can have low urine calcium. And this includes renal insufficiency, patients with severe vitamin D deficiency, or racial differences. Now, if you use the cutoff 0.02, then you almost will, 98% of FHH patients will have their calcium creatinine clearance below this cutoff. However, you can see that this sometimes or most of the time would overlap with patients with primary hyperpara, especially when it is in the intermediate range between 0.01 and 0.02. However, if the pH tend to be low or low normal, then you have a longer list of differential diagnosis. And then you need to have a proper history, physical examination, and you may end up requesting a bunch of tests in order to reach the diagnosis. So in our patient, he have hypercalcemia of 2.82 with phosphorus normal, but he have suppressed PTH. And he have also vitamin D of 83, which is within normal range, and he have hypercalciuria. Besides that, he have normal renal, liver, and thyroid function. And therefore, we are dealing now with a non-PTH related hypercalcemia. So we did a bunch of tests in order to reach a diagnosis, starting with PTH related peptide, which was undetectable. And we did 125 hydroxyvitamin D, which was upper normal limit, which is considered in his case as elevated. Also, he had full body cross-sectional imaging looking for possible underlying malignancy or granulomatous disease, and it was completely normal, apart from the kidney stones, which he was basically referred to initially to the urology clinic. So our patient, from the history, from physical examination, and from a group of blood tests that I'm listed here, we could exclude most of the possible causes. However, sometimes only looking to the trends of calcium and vitamin D can give you a clue what your patient could have. And you can see this patient have hypercalcemia during the months of May, June, and July, which are the summertime. And when his vitamin D25 was 83, his calcium was 2.82. With time, as he was advised to take low calcium and low vitamin D, and with the drop of his 25 hydroxyvitamin D, his calcium dropped down a bit, though it was intermittently elevated. However, he was able to maintain it upper normal limit. And through all this time, his PTH was suppressed. So this lets us think, is there is any possibility of any defect in metabolic pathway of vitamin D? As you can see that the main sources of vitamin D are from diet and skin. And in the liver, it goes through 25 hydroxylation to form 25 hydroxyvitamin D, which in the kidney through 1-alpha hydroxylase will form the active form of 125 hydroxyvitamin D. And in turn, 125 hydroxyvitamin D, which is the active form, can go or can be degraded to its inactive metabolite through the 24 hydroxylase. And therefore, if we have or vitamin D related hypercalcemia could be related either to exogenous vitamin D toxicity from excessive intake of 25 or 125 vitamin D, or it could be related to excessive production of vitamin D metabolites from extrarenal, for example, activation of 1-alpha hydroxylase, or it could be related to a mutation in the enzyme that's responsible for the degradation of 125 hydroxyvitamin D. And therefore, in our patient, with the previous history that I provide and investigation, we could exclude the first two, and we may think of this diagnosis. Could our patient have a loss of function mutation in cytochrome 24A1 gene? So is there any screening test that can predict this mutation? If we think about it, if we have loss of function mutation in this enzyme, this means that the outcome product will be low and the precursor will be elevated. So if I can measure 24, 25, and I can measure 25, and I can measure 125, then if I calculate what we call it molar ratio, which is the ratio between 25 hydroxyvitamin D to 24-25, or 125 to 24-25, and it was elevated, then there is a defect here. And this is what we did to this patient. We measured the molar ratio in a research lab, and it came back elevated. So this is suggestive of a possible defect in this enzyme. This was followed by a genetic analysis for the cytochrome B24A1 gene sequence, which revealed a heterozygous missense coding sequence variant at position 475, resulting in substitution of arginine with a tryptophan. So this patient have this condition that have several names. One of them cytochrome 24A1 deficiency, or cytochrome 24A1 loss of function mutation, and it is one of the established causes nowadays of idiopathic infantile hypercalcemia. You can see that over the last few years, there have been it has been a rich subject in literature, both for the infantile hypercalcemia and the cytochrome 24A1 mutation. And now I will give you a brief view about this genetic mutation, starting from history, transmission, and disease manifestation and the treatment. So actually, this starts initially with the UK public initiative of supplementation of formula milk with vitamin D in order to tackle rickets. However, the 2 years after establishing this initiation, there have been almost 200 cases reported of idiopathic infantile hypercalcemia. It was proposed to be associated with the vitamin D supplementation. However, there was no big evidence because majority of children did not develop it. This leads the UK organization to lower the amount of vitamin D in supplementation from 4,000 to 1,000. And with the subsequent years, actually they noticed that the number of cases reported of idiopathic infantile hypercalcemia have decreased dramatically. However, despite that, still it was a query whether it is associated with vitamin D supplementation or not. And this is an article from 1965, where they already proposed that it was either hypersensitivity to vitamin or a defect in cholesterol metabolism or a defective removal of vitamin D, which could be a possible underlying cause behind this. Till 2011, when Karl et al. From Germany, they reported the first mutations in cytochrome P24A1 that can lead to idiopathic and cause idiopathic infantile hypercalcemia. And they reported 2 cohorts of infants. One cohort presented with typical idiopathic infantile hypercalcemia who were on a small dose of vitamin D prophylaxis, around 500 international units daily. While the other cohort, they presented as if they have suspected vitamin D toxicity because they received very high dose, 600 international bolus. All patients in both cohorts presented almost with a hypercalcemia of 3.5 and above. However, on their screening of other family members, they noticed also that there were 2 family members who are asymptomatic, and one of them actually was having hypercalcemia of 3.7, and the other one have a normal calcium level of 2.4. They sequenced all these patients and that they noticed that all of them almost have homozygous mutation or compound heterozygous. That means they have both allele affected in all these patients. And therefore, for the first time, they reported the loss of function mutation in cytochrome B24A1 is a cause of infantile idiopathic hypercalcemia. And they proposed that the transmission is autosomal recessive. However, a year later, a group of Mayo Clinic has published also a family series or a family tree with the same thing. However, they reported an adult patient who presented with intermittent hypercalcemia, hypercalciuria, elevated 125, normal serum 25, and reduced serum BTH. And they screened his siblings as well as his children. And they found that even his family member who have only one mutation, the patient himself was having biallelic mutation. However, only those who are harboring only one allele defect, that's mean monoallelic, they also hypercalcemic. And one of his son, his calcemia was up to 14.2. His daughter, her calcium actually in birth was 16.4, and it was managed with low calcium and low vitamin D down to 10.3. Also, for the first time, they could report that these patients, they have undetectable or low level of 24, 25 hydroxyvitamin D. And therefore, the finding from their study that this condition actually is transmitted through autosomal dominant with partial penetrance of the trace, and it is associated with absent serum 24, 25, and that such patient could present in adulthood. Also, they came up with the idea of the gene dose effect. And they reported a serial of family members who some of them were actually elderly and some of them have kidney stones. All these patients were screened or genetically for mutations that are mentioned. So they try to compare those who have both allele affected with those who have only one allele affected, so biallelic versus monoallelic. And they reported or they found that those who have biallelic disease, they have more hypercalciuria, and more ratio of 25 to 24-25 compared to those patients who have only monoallelic. However, in terms of kidney stones, both patients with monoallelic or biallelic disease could have kidney stone. And therefore, they suggest the existence of mild phenotype in patients with monoallelic mutation, which may manifest the clinical disease based on environmental factors such as hydration, 25, vitamin D, calcium, and vitamin D intake. Also, the first group from Germany who reported mutation in this gene reported later two siblings with the same compound heterozygous mutation presented differently. The daughter presented with infantile hypercalcemia at 10 months, while her brother presented with nephrolithiasis at age 13. And therefore, they suggested that even patients with biallelic disease can present later on life with milder symptoms. However, this was not in agreement with everyone, and Kuls et al. Actually reported the opposite. They mentioned or they reported that patients with heterozygous carrier, that's mean monoallelic, they were not different biochemically or clinically than patients who have wild type, that's mean normal. And they suggested that from their literature review that those patients who are heterozygous and have a manifestation are the one have elevation in 25 to 25 hydroxyvitamin D ratio. And therefore, they suggest that this ratio may be informative in identifying subject at risk of developing infantile hypercalcemia, irrespective of the presence of homozygous or compound heterozygous or heterozygous mutation. Another point to mention is that sometimes patients with this condition could present in pregnancy with hypercalcemia, and there have been several reports on that, which I will not go in. So, in summary, for the clinical spectrum of cytochrome B24A deficiency, it can present in a wide range of phenotypic presentation, which can range from idiopathic infantile hypercalcemia, or that present basically with acute severe hypercalcemia, to a milder presentation with hypercalcemia that could be intermittent hypercalciuria, nephrolithiasis, nephrocalcinosis, or could be to completely asymptomatic and can present with that through the lifestyle stages of childhood, adolescence, or adulthood. And the reason behind that could be related to gene dosage, or could be to other genetic unknown modifiers, or to environmental triggers like vitamin D intake, calcium, or or sunlight exposure, or pregnancy. So this is a brief review of the biochemical profile of such patient. They could have normal or elevated 25, elevated 125, suppressed 24-25, and elevated calcium, elevated urine calcium, suppressed PTH, and the most important thing is absence of hypophosphatemia, and of course, absence of toxic level of 20 vitamin D. Now, treatment of these patients is mainly coming from case reports, and in general, you give them high fluid intake, avoid excessive dietary sodium in order not to form stones, and specific measure is to avoid dietary vitamin D and calcium intake and sun exposure. In case of severe hypercalcemia, IV hydration or loop diuretics, a trial of bisphosphonate, calcitonin, steroid had variable results. Patients, adult or child who have recurrent nephrocalcinosis, steroid is less efficacious. There are cases of ketonazole and fluconazole use, and also lately of rifampicin. And this actually was one of the first cases where they use ketonazole therapy in the adult patient, with documented reduction in urinary calcium and BTH, and also a trend reduction in total serum calcium as well as 125, though it did not reach significance. Also, this one of the cases where they published, where they used fluconazole, and it has maintained the patient serum calcium as well as documented reduction in 125. And lately, rifampicin have been used in 2 patients with infantile idiopathic hypercalcemia, and it will act through induction of cytochrome B3A4, and this will lead to conversion of more of active vitamin D or 25 into their inactive form. And actually, they found that it could maintain the calcium level and also elevate the BTH in their patients. One of the biggest differential in infantile hypercalcemia for cytochrome B24A1 loss of function mutation is another mutation called SLC34A1, encoding sodium phosphate cotransporter 2A. And actually, it was described by the same group that described loss of function mutation in our gene. And the patient with this condition will have same biochemical profile except for hypophosphatemia. And basically, their treatment will be phosphate replacement. So in our case, we manage the patient just with good fluid intake, low sun exposure, with low calcium and vitamin D intake. And with this measure, his latest calcium was 2.53 and intentionally low 25 vitamin D of 33.4. So in conclusion, loss of function mutation cytochrome 24A1 are distinct causes of non-PTH hypercalcemia. They are rare. Biallelic, homozygous, or compound heterozygous mutation appear to most commonly result in severe hypercalcemic phenotype. However, the spectrum of the disease is broad, and a small minority of patients has been identified in later childhood or adulthood with hypercalciuria, nephrolithiasis, or nephrocalcinosis. Heterozygous carrier may have a clinically significant phenotype, which is usually milder and less overt than those with biallelic mutation, and rarely a severe phenotype has been described in presumed heterozygous individuals. Adults tend to have a broad spectrum of clinical severity at presentation, whereas children are more likely to present with a acute severe hypercalcemia. Clinical effects is mainly renal in nature. Several factors serve as important modifier, especially vitamin D supplementation and dietary calcium. The mutation can exaggerate the physiological hypercalcemia of a pregnancy and biochemical findings that have been discussed before. Also on top of them is the molar ratio of circulating 25 to 24-25 could be a useful screen, especially for heterozygous carrier, and the treatment has been discussed earlier. Thank you for your listening, and I will hand the mic back to Dr. Bidur. Thank you.
Thank you, Dr. Araya. That was a difficult case, but very awesome and interesting. Just to remind the attendees, we have so far 466 attendees. For people who joined recently, this is a semi-accredited activity. If you have any questions for any of the presenters, you can always post it during the session in the Q&A box. It will be addressed toward the end of the program. So we move to our third presenter, Dr. Noura Al-Hassani. Dr. Noura Al-Hassani is going to present today a child with a broken bones. Dr. Noura is the Chief of Pediatric Endocrine and Diabetes at Tawam Hospital. She's also an adjunct assistant professor at College of Medicine at Al Ain University. Dr. Noura's research interests include type 1 diabetes and growth disorders. So with no further delay, I'll hand the mic to Dr. Noura. Kindly, Dr. Noura, unmute your mic and share your video with the audience.
Thank you, Dr. Bidur, for your kind introduction. And thank you for invitation to be part of this promising young leader activity. My talk today will be about child with the broken bones. It will be mainly two parts. The first part is the case presentation. The second part is more of a quick overview in the topic. So our patient is currently at 10 years of age, female. She had been born to a mother 25 years preemie with no significant past medical or surgical history. She had antenatal scan showing abnormal long bones, more of about long bones, deformity, but no specific fractures even mentioned. Delivery was at Tawam as a term by cesarean section due to breech presentation with a normal Apgar score. Postnatally found to have a birth weight of 2.1 kg with length of 38 centimeter, were both below the normal centile for the age and gestational week.
There is no dysmorphic features in general, with positive craniotapes in the head with softening of the bones. There was a significant bowing of the lower limbs and a positive pain in the left femur with more of crying and difficult to move the left femur. Family history was negative, except mother's sister had Sanjat-Sakati syndrome. For those who don't know the syndrome, it comes with dysmorphic features, growth failure, and hypoparathyroidism with significant hypocalcemia. So initial labs actually was within normal bone profile, calcium, phosphorus, magnesium, mildly high alkaline phosphatase. X-ray, the left femur showed a displaced diaphyseal fracture of the left femur, a 3 millimeter displacement fragment ventrally. So the NICU team, they proceed with the bone survey, and I'm listing here the report as it was difficult to get the film itself, just to show you how significant or bad it was. It showed in general, generalized significant osteopenia with multiple fractures, old and new. As you can see here, in the pelvis, there is healed fracture at the right femur and completely dislocated fracture of the left side. The spine, significant osteopenia. The right lower extremity malformation with abnormality of the femur, significant widening of the metaphyseus. There's 2 fractures in different ages, proximal aspect, distal aspect of the tibia, very small fibula, another fracture in the distal tibia. In the arm as well, moderate widening of the proximal metaphyseus, the skull abnormal calcifications. There was as well ribs, the fractures, and the very tiny ribs with, as we said, the fractures at different age. So what is the diagnosis here? Frequent fractures in children has a long list of differential diagnoses. For this patient, based on the clinical presentation, the age, the lab, and radiological findings, it goes more with what we call osteogenesis imperfecta, with possible type 3 OI. Definitely, patient had been assessed that time by the ortho and by the genetic who sent for gene for the type 3. We started managing this patient with pomegranate infusion. She received her first course at age of 4 months, then continue as an IV pomegranate every 3 to 4 months. But it was not on regular basis. It was here and there between UAE, UK, Germany, US, as she was frequently going abroad, mainly for issue of the bone procedures. And there she usually stay long duration, at least 6 months. Last time when she was on 2018 here, she has been shifted to zoledronic acid infusion. What about her genetic test results? The initial test done for type 3, COL1, A1, and A2 came back negative. So our genetist sent a whole exome sequence. It came back on 2014, and it was positive homozygous pathogenic variant, specific variants in the Libri gene, which is known to cause type 8 osteogenesis imperfecta. Last follow-up of this patient, last DICSA at Tawam done, it was at age of 7 years, where you can see the bone mineral density, still poor Z scores. And if you notice in pediatric, we are using the Z score, not T score. So total minus 3.3 with the spine of minus 2.5 and lowest for the femur. However, there's some improvement in the bone mineral density itself compared with the previous one. Patient is still under multiple series of ortho procedures and surgeries, currently under a wheelchair with abnormal gait. She has still fractures, even with the treatment. She continues to have some fractures, initially 2 to 3 times per year, but recently around once per year. Last infusion taken was here in our hospital, August 2020, and the plan definitely to repeat DEXA scan. So is this case has been end? No. After a year and a half from treating this patient, we has been consulted to see another neonate on day 2 of life, late preterm, had history of multiple fracture in utero. And at that time, we discovered that this patient is actually the sister of our patient, who at that time was 18 months old with osteogenesis imperfecta, suspecting the type 3, and she was already on pomegranate infusion courses. A patient clinically, other than this point or fractures, she was much better than her sister, clinically doing well, tolerate oral, on room air. On examination, again, no dysmorphic features. On room air, there was obvious short limbs with some bowing of the legs, both fits internally rotated, not moving the right upper limb, which was adducted in a pronated position. Here is her skeletal survey, which it shows almost same multiple fractures in both femurs, bowing of the fibula and tibia, both sides, also fractures in the lower 3 ribs on the left side, no fractures on the right forearm, and old tend to be more of an old fractures. Again, we sent definitely while patient started on a treatment, and while treating her again in 2014, when we get the result of her sister, we sent the same gene to this patient and proved to have the same finding exactly, type 8 osteogenesis imperfecta. So now we will move to the second part of the presentation, which is more of a quick overview on osteogenesis imperfecta. What is the definition, prevalence, clinical presentation, workup differentials, and finally management in pediatric population. So osteogenesis imperfecta is the brittle bone disease. It is mainly an inherited heterogeneous group of connective tissue disorder. In general, the incidence is 1 in 20,000 births. In UAE, there was one study done by Dr. Ghazali in 2003, where she was looking at the prevalence of the osteochondroplasia. And on screening 38,000 births, there she found 36 with skeletal dysplasia, of whom 2 were of osteogenesis imperfecta, giving the incidence of 0.52 per 10,000 births. She did state at that time, or in that article, that it was higher than the other population, which was at that time 0.37 per 10,000. So what is the pathogenesis behind osteogenesis imperfecta? The primary defect here is the disturbance of the production and or subsequent assembly of the collagen type 1 by the osteoblast. So this results in reduced bone mass, abnormality of the cortical thickness and trabecular structure, defect in the bone matrix, which will end with increasing bone fragility and frequent fractures. So as you can see here, in a normal bone with increasing distress and strain, the bone can absorb energy, and it's presented here of the area under the curve till it reach a point where it fail the stress and the fracture that occur. While in an osteogenesis imperfecta bone, there is a less tolerability for the energy with this increasing the stress and the strain, and the area with less area under the curve, so easily to be fractured and faster than the normal bone. So what about the types of osteogenesis imperfecta? Before we proceed with this, let's have these 2 poll questions. So for you, or the audience, in general, what do you think? How many types of osteogenesis imperfecta are well established so far? Is it 4, 7, 10, or more than 10? You have 15 seconds to answer. Answer now, please. I know most of the audience are probably adults, so we would like to know your opinion regarding osteogenesis imperfecta and how much you know about it. So 39% are saying it is 4, 26% 7 types, 14% 10, and 22% more than 10. Actually, osteogenesis imperfecta, it was classified initially in late 1970s by the silent classification, mainly into 4 types, type 1 to type 4. However, which is mostly it was that time more of depends on the severity of the types. Type 1 is the mild form, type 2 is the most lethal neonatal form, type 3 and 4 is more of a moderate to severe. However, more and more genes has been discovered and more types has been classified. So currently, actually, it is more than 10. What about the inheritance? So what do you think? How osteogenesis imperfecta usually inherited? Is it autosomal dominant, autosomal recessive, none of the above, or all of the above, autosomal dominant and recessive? Again, you have 15 seconds to answer, please. So we get the answer. Most of the audience, 39%, saying all, autosomal dominant and recessive, while 31% autosomal recessive, 24% autosomal dominant, and 6% none. Again, with initial classification, the 4 main types, it was mostly autosomal dominant. And I do remember when we were students, we were always stating osteogenesis imperfecta as one of the examples of autosomal dominant disease. However, again, with these new genes, discovery of new genes and mutations, they found more of an autosomal recessive forms as well. So the answer is yes, all of the above, autosomal dominant and autosomal recessive. Another classification is here. This is a latest one, where they classify the types of osteogenesis imperfecta according to the mechanism of the disease itself. So defect in the collagen synthesis structure or processing, it counts for around 85 to 90% of the types, whereas the mutation mostly in the pool 1A1 or A2, and again, it is mostly autosomal dominant. However, other causes and other types could be due to post-translational modification of the collagen, where it includes a more of an autosomal recessive, and here is type 8 of our 2 siblings. It could be a collagen folding or cross-linking, or it could be a defect in the bone mineralization. Beside the last group, could be defect in the osteoblast differentiation. So more and more, we learn about what is the mechanism and pathogenesis behind the osteogenesis imperfecta. Okay, what about the clinical manifestation? Okay, what do you think in general? What is the most prominent sign of osteogenesis imperfecta? Is it the blue sclera, the short stature, recurrent fracture during childhood from minimal trauma, or abnormal teeth? Again, this is a question for the audience. You have 15 seconds to answer, please. Okay, do we have a results here? Yes. 65% majority of the audience recurrent fractures during childhood from minimum trauma, while 14% blue sclera, 11 short stature, and 10% abnormal teeth. And you are right. The most common streaking sign of osteogenesis imperfecta is the bone fragility and frequent fractures. Other features you can see is the short stature, bone deformity with scoliosis, skull deformities, blue sclera is there, hearing loss more with type 1 osteogenesis imperfecta, abnormal teeth, dentinogenesis imperfecta, increased laxity, wormian bones, increasing bruises and bleeding. Those are examples of the blue sclera. Usually you can see the dentinogenesis imperfecta and the clear-cut fracture. Here is an example of the most severe one, the lethal type 2 osteogenesis imperfecta in a 23 weeks fetus, where you can see a triangular face with more of a bowed legs and shortened limbs. There is as well no mineralization of the skull and multiple fractures all over the long bones and the ribs. What is the differential diagnosis? It is very important to exclude or you keep in your mind the other causes of frequent fractures as we were talking about earlier. So it could be secondary to rickets, to hypophosphatemia, osteomalacia, skeletal syndromes, such hypophosphatasia, for example, or idiopathic juvenile osteoporosis. Finally, child abuse definitely should be end of the list, not the beginning of the list. And for this, you need definitely to do investigations, lab and X-ray imaging. So for labs, you will start with bone profile to rule out, for example, the rickets. Usually on osteogenesis imperfecta, bone profile are normal. Vitamin D could be normal, could be low. Usually they do have an elevated alkaline phosphatase. There is hypercalciuria, although this was found even in patients with no long term of immobility and no renal disorders. Bone markers could be done for bone formation, where C-terminal lipopeptide could be low in OI, while for those for bone resorption, it could be higher. The imaging could be done definitely to start with the X-ray, looking for the fractures, the radiological findings, then the DEXA scan for mainly the bone density, and finally genetic test. There is no specific protocol in managing or approaching such patients. This is one example of approach in Canada, and those who are suspecting OI after history, after the bone mineral density radiograph and biochemistry, you suspecting OI, then you need to go to the OI panel request. If it showed a disease variant, then that's it, it is there. If it is not, then you will go to the whole exome sequence. If you got any unclassified variant, then you need to do a surrogation studies, and this is definitely with the help of your genetic team. What is the management of osteogenesis imperfecta? Unfortunately, there is no cure for OI. The main goal of therapy here is to reduce the fracture rate, as well as to prevent the long bone deformities and scoliosis, to minimize the chronic pain, to maximize mobility and other functional status. The treatment definitely is a multidisciplinary team approach. You need, beside the physician or endocrinologist, you need the physiotherapist, dietitian, psychologist, you need definitely the surgeon or ortho. First thing, dietitian is very important to maintain the diet. It is very important to maintain the calcium and vitamin D within the normal level. So probably they will need supplements of vitamin D and calcium accordingly. You need the physiotherapy. And finally, with surgery, orthopedic surgery, it is their key rule is the fixation of the fractures and the correction of limb deformities. What the options of treatment we have in pediatric, unlike the adult, we don't have many options treating osteoporosis. So for patients or pediatric patients with OI, it is main therapy is the bisphosphonate therapy. Yes, there are multiple or few studies here and there of different regimens of adding, for example, the estrogen, adding growth hormone to the bisphosphonate, others such using the synthetic PTH or denosumab. However, all it has its own side effects. All the studies are of few numbers and not for a long-term studies. So need further investigations. The idea of bisphosphonate therapy here is mainly it increase the survival of the osteoblast and osteocytes, inhibiting the osteoclast, so decrease the bone resorption and increase the osteoblast survival, ending with improved bone mineral density and the fracture outcome. Bisphosphonate treatment available in pediatric are listed here in the table. Unlike the adults, the preferred bisphosphonate in pediatric mostly actually is the IV bisphosphonate therapy. Why? Because the oral It has the GI side effects, gastroesophageal ulceration and esophagitis, typical to be used in young children. Beside, again, no many studies. Pomegranate has been studied long term, and at least for the last 20 plus years. Still, there are some oral medication studies there, and it shows a good promising results, such improving in bone mineral density, but not in decreasing the fracture rate. We are in Tawam, we are using mostly, we were using actually the IV pomegranate, where it is used as daily injection or IV for 3 days, as a courses every 2 to 4 months. The dose was 0.5 to 1 milligram per kg per day. And this has been shifted to zoledronic, similar to many other centers everywhere. Why? Because zoledronic is much easier, and it doesn't require this long-term or long admission. It is as single injection given every 6 to 12 months with a dose of 0.025 up to 0.05 milligram per kg. Side effect of bisphosphonate is mostly the flu-like syndromes, most commonly the fever. Then there is the malaise, weakness, the electrolyte disturbance, such hypocalcemia, which could be symptomatic. Later effects, usually with long-term use, could be delayed bone healing, and this has been reported more with those doing rooting procedures. Drug-induced osteoporosis associated more with higher doses and longer duration. GERD, again with oral. Other potential side effects has been mentioned here. It is actually reported in adults, not in pediatrics, which is the atypical femur fracture or the osteonecrosis. Example of the benefit of pomegranate. Again, there are multiple studies, although less number are controlled and placebo-controlled studies, randomized studies. This one more of observational study of 30 children with osteogenesis imperfecta, severe 1, type 3 to type 4. And they found here that those patients treated with pomegranate for 1.3 to 5 years, to start with, they have very poor mineral density with Z score of average minus 5.3. Post-treatment, it has been improved to 3.4 plus minus 1.5. So it was significant improvement, beside improvement in the vertebral area as well, before and after. And it reduced the fracture by 1.7 per year as well. Another example of the zoledronic acid use in children is this study done on Italy Center, where they looked at 14 patients and they've been treated with zoledronic. The median age was 6 years, and half of them are 6 are type 1, 6 type 3, and 2 type 4. On those patients, they found that zoledronic acid decreased the number of the bone fractures and the pain in children. It improved as well the functional status. Most common side effect here was fever and bone pain. What about the other options we did mention, and what about its use in adults? I suggest if you are interested, you can read this article, very useful in treating osteogenesis imperfecta in adults, where they did mention the trials in using the other options
It seems some technical issues. Until the technical issues is resolved with Dr. Noura, we'll move to our fourth presenter, Dr. Ala Eddin. Okay, Dr. Ala Eddin is going to present today presentation skills. Dr. Ala is a consultant endocrine at Tawam Hospital, and he's the current president of the Sudanese Diabetes Association of the Gulf chapter, and he is a very active member of research group and have published more than 70 original papers and review articles. The floor is yours, Dr. Ala. Kindly unmute your mic and share your video.
Thank you very much, Dr. Aboudur, for the nice introduction. Today, first of all, I'd like to thank MLS Diabetes Society for continuing with this very useful forum. As Dr. Fathi and Dr. Aboudur said, it has started last year, and it was a face-to-face presentations, and it was extremely useful to the young participants. This presentation is actually going to be short tips on how to give an effective presentation. It's not about the content of the presentation, the scientific content, and it is not about the slides and how to prepare the slides. It's how to present yourself. And before I start my presentation, I would like to share with you this photo. This photo actually, probably you've heard of what's going on in Sudan these days. This photo shows how the floods and the Nile has moved inside the residential areas, and you can see how many of the houses are actually flooded with water. And to show you the extent of this, these are two pictures of the Nile in Sudan. The one on the right side is the White Nile, and the one on the left side is the Blue Nile. And they meet exactly where this boat is moving. This was before the floods. If you can see it down now, this is a recent photo with the floods. You can see that the island on the right side has been wiped completely, and it is not there anymore in the picture. And part of the island on the left side is also covered with water. And I'd like just to send a message to my people in Sudan and tell them that غدا نكون كما نود ونلتقي عند الغروب وغدا تجف مدامعي وتزول عن وطني الكروب إن شاء الله. So our presentation today is about how to give an effective presentation. And I'd like to start this presentation with a polling question. The polling question is, this is a question that has been done previously, and I can show you the answers. However, I'd like to know your opinion about it. So what tops your fears? Is it flying or sailing or snakes and insects or public speaking or even death? So this is the first polling question. You have 15 seconds to answer. So most of the people actually in the audience are afraid of snakes. None, actually around 4 to 6% are either afraid of flying and sailing, and around 26% are afraid of public speaking and death. So if you can see here that the fear of death and public speaking are almost the same. So, and this is actually, can you move the, yes. This was the answer actually for the poll that was done previously for public, and they said public speaking is their number one fear. And that actually makes sense, because we say human brain is amazing. It works continuously until you get to speak in public, where you stop and you'll not be able to think and breathe and talk. So to start this presentation, I'd like to give you another polling question. And it's important to know the answer to this question for a simple reason. We need to know, why do we present? So what is the aim of presentation in medical field? As a physician or as a doctor or as a student, why do you present? Do you present to show people your knowledge, or to teach other people and convey your knowledge, or to promote for specific drugs? Do you present to earn money or to earn knowledge? Or you do present for all the previous reasons? Again, you have 15 seconds to answer. It might be, maybe all of them might be the answer, but I want you to think of what exactly the single reason you think is the reason. Okay, so most of the people thought for all of the above. And around 41% of you said you present to teach and convey knowledge. And I guess this is one of the most important causes. Yes, you might present for any other reason, but this is one of the most important reasons, to teach and to convey knowledge to other people. So your aim then is to allow people to get information. This is a very famous diagram in education. And it basically says, and it talks about retention of knowledge. So if you give a lecture, by the end of your presentation, people will retain only 5% of what you said. If you go and read, you retain only 10% of your knowledge. So the more active learning process, you get more better retention. And look at it, 90% retention rate if you teach other people. And that's the beauty of teaching and presenting. So you learn and you teach others. And I always say, this is zakat al-ilm. So you learn and you teach other people. So if your aim is to teach people, you need them to retain knowledge. So how do you do it? How do you do it in an effective way that allows people to retain the knowledge you need them to know? So I think there are three important points that you need to know. First one is you need to know your audience. And this is extremely important, because if I have to present for medical students, I should not go and talk something very highly specialized where people, even students, wouldn't know what you're talking about. You need to know what to present. And this is extremely important, because if you go and read about a topic, you will find thousands of information that you think, yes, people need to know this, but you should know what to present to people. And again, most important is you should know how to deliver that knowledge. So to do this, number one, know the details of your place, location, and the audience. And it says usually it's sometimes difficult when you have a mixture of audience. You have medical students, you have GPs, you have specialist internists, you have endocrinologists, you have, so if you have that level or mixture of attendees, then you have to make your presentation in a way that suits all those people. So it has to be, they say, it has to be not very low level of knowledge, not very high level of knowledge. You should be somewhere in the middle, something around 60 to 70% of the amount of knowledge that needs to be delivered. Details of the topic, this is an absolutely important point because you are going to present to people, you should master your topic. And without knowing your topic, definitely you'll not be able to deliver it in a proper way. And second, you'll not be able to handle the questions at the end of the presentation. So these are of utmost importance, are not going to be covered here. But very important to know, what do you want to tell people? It's always said that little is too much. So give little of information that you make sure people get it by the end of your presentation, rather than giving each and every information that you know in your mind. And by the end of your presentation, they will come out with only 5% of your talk. So make sure that you know how you want to deliver it. Do you want to deliver it with media and videos? Do you want to talk? Do you want to give it to them in one of the new ways of teaching, like we call it a flipped class? You send them the material and then you come and do discussion in the class. It's very essential also to have your presentation in very specific flow. Make it flow that people wouldn't notice that you jumped from one topic to the other while you're presenting. So people shouldn't feel that. It should go very smooth from start to the end. And this is very important. And make sure that you always put conclusions at the end of your presentation. Now, an important tip is to try to make an impressive start. People always see the first minute you start talking, people would either decide they are going to listen to you or not. So the start is the most important thing you do. Make it very impressive, make it unforgettable. How to do that? You have probably to start with a story or even a personal experience. People will remember that. It helps you to bond or to make sort of rapport with you, between you and your audience. So make it a story, make it nice. People love stories. If you start with a story, people will listen, 100% will listen to you. And I'll give you examples of a start, and then I will check with you which one you like. Now, let me give you this example. You have been asked to present a talk about use of insulin in diabetics or in diabetes. Now, let me share with you the first way. This is the first way I would say it. I will come and stand and say, well, you all know that diabetes is a chronic disease. It has a prevalence of this much percent, and it is expected to increase. We would expect to see around 6,400,000 people by the year of 2045. And the highest prevalence of diabetes is seen in the MENA region, where the prevalence is almost 20%. 1 in 5 patients will be having diabetes. So this is one of the ways you start when you say it. Now, this is a second way of starting the presentation. I'll say, do you know that in early 20th century, diagnosis of diabetes was equal to a death sentence? People with diabetes at that time didn't have any treatment available. And that's why when insulin was discovered, the Toronto Daily Star journal came with a main sheet that says, Toronto doctors are on track for diabetes cure. And that has made a huge propaganda in the media that time. And after that, starting from simple insulin, we started to develop, and we have now currently the most modern types of insulin, or what we call them new generation insulins. So this is a second way to start your presentation. Now, A third way of doing it, I would say, well, I'd like to tell you a story about Elizabeth Hughes. This is a young girl who was diagnosed with diabetes in 1922. This lady has an amazing story. She managed to describe this story in one of the books published recently. Elizabeth Hughes was one of the few people who managed to be treated with insulin in 1922. At that time, insulin was only short-acting. They didn't have this long-acting insulin. And she is here describing her experience. This is part of her notes when she was admitted to the hospital. She was extremely emaciated. She had edema of her ankles. She had dry skin, scaly, brittle hair. And she said, this is her description to the insulin injection. She said, imagine I have to take 5 cc's at a time. Isn't it awful? At that time, we only had 2 cc syringe. So Blanche is her nurse. She gives it to her. She unscrews the needle and she leave it sticking in me. She fills it again. And then until she complete the 5th cc, I feel my hips would burst. I even had once an experience of anaphylactic severe reaction persisting for 2 days, generalized skin eruption, nausea, and vomiting. I thought I was going to die. And that was the early experience with insulin. Now, we're lucky to have new generation insulins, long-acting and short-acting insulin available as pen. So this is the third way. Now, I'd like to get your opinion. Which start did you prefer? Did you like the first scenario, or the second scenario, or the third scenario, or none of them was good? So this is a polling question, and you have again 15 seconds to vote. Around 46% of you, or 48% actually, loved the third way of start. Around 33% like the first one, and around 12% love the first one. Do you know why? Because the third one is a story, while the second one, it has part of it is a story, but it was a short story. It didn't convey the message you would like to do. The first one is the usual presentation that we see with each and every talk, where people starting their presentation with prevalence of diabetes. Diabetes is a chronic disease. Diabetes is associated with cardiovascular risk. So now, important tips. As I said, remember, too little is too much. Don't talk too much. Don't give a lot of information. Make your whole presentation with a story. Start with a story, and then make the presentation itself is a story. How did you start doing? How did we develop the insulin? And then what is new about insulin? What are the benefits of new insulin? Until you come to conclusion. Try to have some sense of humor. People like people with humor. If you give some humor in your presentation, it makes it very elegant and nice, and people will remember it. Now, an important point is to have some pauses in the middle. Many of the most famous speakers, leaders, do have pauses. The idea of the pause while you're talking is to allow information to sink. People be able to process the information, and then they work on it, or they understand it, and then you proceed and you continue with your presentation. it's very essential to make an eye-to-eye contact with your audience, especially not definitely with the virtual presentations. However, it's very essential when it's a face-to-face presentation is to make an eye-to-eye contact. Why is it essential? When you make an eye-to-eye contact, each one of the audience will feel as if you're talking to them personally and you're not just standing there and talking. And it's very essential to give examples from real life while you're talking. One of the most important parts of giving an effective presentation is to speak effectively. It's very essential to speak effectively. I'm going to tell you why in a while. How to speak effectively? You need to vary the tone of your voice. Sometimes make it loud, sometimes go a bit less loud. Vary the tempo of your speech and project your voice effectively. So these are very important points. Now, I'd like to show you this variation in voice. We call it inflection. And I'm going to do this exercise for you. Now, this is one sentence, and I'm going to say it in different ways, so it gives different meanings. So the first one, the sentence says, I didn't say you hurt my feelings. Now, if I'm completely denying that I am the one who said that, so I would say, I didn't say that you hurt my feelings. I did not say you hurt my feelings. That means probably someone else did. Now, if I say it in this way, what would you understand? I didn't say that you hurt my feelings. I didn't say you hurt my feelings. It's a strong denial. I did not say that you hurt my feelings. But if I say it this way, I didn't say that you hurt my feelings, it means that I did not verbally say it, but you might have suspected that from my talk, but I did not say it. Okay? Then if I want to say, maybe someone else hurt my feelings, I would say it that way. I didn't say you hurt my feelings. So you stress on you. You say, I didn't say you hurt my feelings. So it means maybe someone else hurt my feelings. And if you want to say that you might have hurt X, but not me. So you would say, I didn't say you hurt my feelings. So you stress on my. So what I wanted to say here is stressing on specific points, varying the tempo of your voice, projecting your voice, makes sense of your talk. You convey different messages from the same sentence with the way you talk. Now, again, it's essential to show confidence. How would you do that? You know, many people come behind the podium and they stand behind the podium and they start talking. You know, diabetes is so and so and so, and today we're going to talk about so they just stand there, they don't move at all, and they're standing as if they're sitting. If you move around, you will show confidence. So walking around shows confidence in yourself. That's one. Second, sometimes when you walk around and you go, especially with a small crowd, and you walk between people, the message will be delivered in a better way. People will feel you are around them, you are giving them the message in a close distance and not standing away at the podium and talking to them. You have to have the perfect posture you should have, including your posture and your chin. It has to be in a perfect way. Don't be shy. Show people you're confident. And this is with your posture. So it's very essential to project your voice, show confidence in yourself, walk if you can while you're presenting, and have your posture and body language properly. Now, why is it important to focus on voice and body language? This is a survey done, and they found that the lasting impressions from any talk are basically related to a couple of things. 55% of the long-lasting impressions, you get it actually because of your body language, not because of the content, not because of anything else. So your body language make better impressions. You get a longer lasting impression only with your body language. Changing your voice and projecting your voice and making inflections in your voice, you get another 38% lasting impressions. So if you get a full sort of if you look at the impression, you get it mostly. This is more than almost 88% of your impression. You get it only from your body language and from your voice projection. So train yourself to project your voice, train yourself to talk clearly and show confidence in yourself, and try to use the body language in a proper way. However, the rest of the content or the rest of the impression, only 7%. Only 7% you get it because of the content of your presentation. So this is an exercise time, and I want you to do one thing. We cannot do it virtually. Such presentations actually should be done in sort of workshops where a small group is there and everyone will get the chance to present and to exercise, to do exercise. Now, I'm going to show you a sentence, and I want you to take a picture of it and try to do it yourself at home and see how you will do it. So this is again a training on inflection. You can say, I didn't say he lost the keys. Say it the first time to answer this question. If not you, if you did not say it. If not you, who said it? Again, I did not say you lost the keys. So if you wrote it, you did not say it. If you wrote it, how would you say it now? I can give you an example. For example, I didn't say he lost the keys. If you want to say he wrote it, I didn't say that he lost the keys. Say, you stress on say, that means, yes, you might have just noted that, you might have wrote it. So, and try to answer the rest of the questions. As I promised you, this presentation is going to be very short. These are just tips for a way of presenting effectively. What I did now, and I practiced some of this, I started with a story. I used infographics and I used video initially to put the title and my name. I gave examples of how to start your presentation, whether to start it with a story or just some numbers that this is the prevalence and so on. So I tried to make it more interactive by using polling questions, despite this being virtual. It would have been more interactive when people are around you. I tried to use the pauses. I tried to pause in the middle. People who attended actually my last presentation on presentation skills, I told them, I love talks of Barack Obama. Barack Obama is one of the best people worldwide known to give talks. He used the poses frequently. Go to YouTube and check any of his talks. He is the master of poses. Now, I tried to make inflections from my voice while I'm talking to you. And I tried to use body language, although it's extremely difficult in virtual meeting, but what I have, my hands and my voice, so I tried to use them to make impressions from this talk. So remember these, train, and I thank you very much for being with us. This was my last slide. Thank you.
Thank you, Dr. Alauddin. That was a gorgeous presentation, as usual, mashallah. For Dr. Noura's Al-Hassani talk, there was unexpected connection interruption. Dr. Noura has only 2 slides left, so she was almost done with her presentation. Dr. Noura, that was an interesting, fascinating talk, and though it's a rare condition, but thanks, Dr. Noura.
Thank you all.
So as we promised the attendees, we'll be having now our Q&A session. I would like to invite the panelists for the discussion. I have filtered the questions according to the theme. Following the Q&A session, we will be having a sponsored symposium by Servier. It will be presented by Dr. Jalal Nafash. So we start with our questions. I'll start with the theme of osteoporosis. The question is directed to Dr. Asma, posted by Dr. Waqar. I have a CKD patient, dialysis on denosumab usually causes severe hypocalcemia. Is there any alternative for management of osteoporosis in dialysis patient?
So talking about CKD and BD, it's a very difficult topic actually, and we don't have any data. It's all only opinions, and there is here and there some case reports reported about trying medications in CKD 4 and 5, especially in dialysis patients. So the approved medication is denosumab. Off-label, sometimes people are still using bisphosphonate or teriparatide in patients, but we need to bear in mind the pathophysiology of CKD and BD, and we all know that there is 3 types: a dynamic bone disorder, and patient with osteitis fibrosis cystica, or the patient is having osteomalacia. So I need to do all the bone markers, bone turnover markers, know in which category the patient is falling. If the patient doesn't have a dynamic bone disorder or osteomalacia, so you still can use denosumab. But I will load the patients with calcium and vitamin D, make sure the patient is having a higher normal level of calcium, vitamin D, phosphorus, and magnesium before giving the denosumab. Teriparatide is given if the patient is having a dynamic bone disorder. And there is no much study regarding the efficacy, if it is really improving the dynamic bone disorder, and we're not sure if it is worsening the secondary hyperparathyroidism. Regarding bisphosphonate, there is no much data, but some of the bone experts is using it in half dose of the normal if they using it. But bottom line, give the phosphate binder, load the patients with calcium, vitamin D, make sure that the patient's vitamin D at a normal level. Cinacalcet if the patient is having very high PTH to decrease the PTH level. Denosumab if the calcium level and the higher normal. Though in my practice, I really don't tend to give it to the patient unless the patient is really fractured. And the bone expert is always insisting that we need to do the bone biopsy, the double label, the tetracycline before giving the patients, because that will give us a better idea if the patient is having a dynamic bone disorder or not. I hope I'm answering his question.
Yeah, it was well answered, Dr. Asma. The second question is posted to you also, Dr. Asma, by Dr. Hadiy al-Buhairi. For how long denosumab should be used?
Based on the Freedom Extension study, it was a 10 years study, and the study showed that there is no really time limitation for how long we should treat the patient. This study showed that the patient is getting a benefit from continuing the treatment, less risk of side effects when we're continuing the treatment. There is an increase in the BMD with longer treatment duration, and there is fracture reduction with continuing. So really, there is no reason to stop the medication as long as we're achieving, treating to the target and achieving the response from the treatment. But bear it in mind, whenever you're going to stop the treatment, you need immediately to switch to other anti-resorptive bisphosphonate to avoid the weaning off of the efficacy of denosumab.
Okay, the third question for also regarding osteoporosis, posted by Dr. Amira Zahrani. What is the definition of treatment failure? Question number one. And the second question posted by Dr. Amira Zahrani, if patient was on bisphosphonate for 10 years, repeat DEXA showed deterioration, what should be the next step? So first question, treatment failure definition.
Treatment failure, it's mainly if we're monitoring the treatment and we're looking at the DEXA scan, the patient is not improving the DEXA scan, and I'm usually, in my practice, I'm using the bone turnover markers. So if we're using the bone turnover marker and the patient is not really achieving a good response to treatment, and this is when you're, I used to do it like before starting the treatment, 3 months after starting the treatment, then every 6 months to follow the response. So if the patient didn't achieve the least significant change with the bone marker, or the DEXA scan at 1 year didn't show improvement, or the patient's first fracture, I wouldn't during the 5th year, doesn't consider as a failure of a treatment. But if the patient had a recurrent fracture during the treatment, I would consider it a failure. Then I have to go back to revise my secondary causes. Maybe I'm missing something with this patient. I need to check the adherence of the patient. You need also to check the technique of giving medication, especially if we're using the injectable medication. Moreover, I need to look at the techniques of doing DEXA scan. I read the DEXA scan myself, look at if it is T-score or Z-score based on the patient's age. Then I'll go further to assess if the patient is failing really the treatment. Then you talked about the premenopausal, or what was the second question?
If the patient was on bisphosphonate for 10 years, repeat DEXA showed deterioration, the value, what should be the next step?
Again, I need to go, and you need to, the physician need to go and look at the DEXA. The interpretation is correct, the positioning of the spine is correct, there is a fracture or not in the spine, the bone turnover, if all this is showing that the patient is really not improving, then this is the time to switch to another medication. So another anti-resorptive like denosumab is much, better than continuing giving only the bisphosphonate.
Okay, so checking the validity of the result, then if it's true, then we switch to another agent.
Yes.
I'll go to the PTH questions. This is the questions directed for Dr. Raya. When should we refer to genetic testing for cases of primary hyperparathyroidism?
Very good question. So you would suspect syndromic or sporadic primary hyperpara to be genetically related in patients who are young. There is no specific cutoff age. Some people suggest below 35, others below 45. I will refer below 40. You will suspect genetic when there is also family history. So you would refer young patient with have a family history of PTH-related hypercalcemia, patient who have multiglandular disease, and patients who have other associated tumors or symptoms that is suggestive of syndromic causes like MIN1.
Okay, thank you, Dr. Araya. There is another question related to parathyroid to you, Raya, and whomever wants to, from the panelists, to answer. What is the cutoff for the PTH value that favors that this is a PTH-dependent hypercalcemia? In our department, we are using the picogram per milliliter. So I think they mean when it is a mid-range. How would you say that this is PTH or non-PTH mediated?
Okay, very good question. So we say PTH mediated when it is mid or above the mid upper above that's mean upper normal limit, above the midpoint, or above the upper limit. When it is below the midpoint or low, this is suggestive of non-PTH related. However, you have to bear in mind that there are few case reports, and I haven't seen such case, but you could encounter it, where the PTH is undetectable with your assay. And this could happen when the adenoma is secreted mutated or apparent PTH. In such case, you have to go with the overall picture. If the picture and the level of the calcium level is suggestive of a primary hyperpara, and you did ultrasound and you see adenoma and you did a localizing study, and your overall clinical judgment suggests primary hyperpara despite low PTH, then go for surgery. This is primary hyperpara, could be due to mutated PTH. Of course, if you are in a research center, you could run a mutation, in both the adenoma and germline, and you compare. However, this is only a research thing. However, if you think of it, you can have PTH suppressed or undetectable in patients with a primary hyperpara.
That's very interesting one. The question to Dr. Noura, what is the most common osteogenesis imperfecta type in our region?
Types of osteogenesis imperfecta, as we were saying, 85 to 90% of the types secondary to mutation in the COL1, A1, A2 genes. So it is type 1 to type 4. Among current practice and among my own, for example, patients, I will say type 1 is the most common. However, again, unfortunately, we don't have a recent studies collecting many numbers or good numbers of osteogenesis imperfecta. So it will be a very good idea to start having such a cohort study, looking after all the patients of osteogenesis imperfecta, and at least in our country or different areas, and look at their genetic and phenotypic features.
Okay. Thank you, Dr. Noura. Another question related to osteogenesis imperfecta. Are you facing delayed presentation of osteogenesis imperfecta in our community?
Presentation osteogenesis imperfecta depends actually more on the severity and the type, as we were talking about. So most of the severe, definitely they will present anyway earlier, such neonatal or infancy in early childhood. Maybe the point here is more with those mild cases, mild types appears later on childhood or later adolescence or even on adults. So I believe this is a very important awareness point for you as family physicians, for those internists, to keep it in their mind whenever they are seeing such patients with frequent fracture.
I see. So it depends on the type of the osteogenesis imperfecta. Okay, another quick question. Is 25 hydroxylase deficiency is a risk factor for osteoporosis with time?
The question is 24 hydroxylase deficiency. Actually, very good question. So in our case, we did not do DEXA scan. We didn't do it. And some of the reported cases, they report osteopenia, especially the one from Mayo. However, as you, the study that I mentioned did not find any difference in patients who are carrier, the one from Italy, they did DEXA scan. They found no difference. So because of rarity of the disease, we cannot reach a conclusion. However, from the case reports and elderly, most of them, they present with nephrocalcinosis. No one mentioned increased risk of a fracture or multiple fractures. So this is also a point to learn that maybe they are not at increased risk of fracture, maybe. However, I think collecting cohort of, with the time, because it is rare disease, you cannot reach a conclusion definitely. But good question.
Yeah, thank you, Dr. Raya. Another question posted by Dr. Najla Daiji. If patient was an ex-smoker, would you add this as a risk for FRAX calculator, Dr. Asma?
No. Ex-smoker is not a risk based on the FRAX risk factor.
Okay, so a past history is not considered a risk factor. The other question is directed to Dr. Noura. What are your parameters and follow-up with in osteogenesis imperfecta? Why during treatment?
During treatment with bamidronate or with in general bisphosphonates in those patients, definitely what is very important is to start with the clinical assessment, looking for rate of fractures, looking for the growth parameters, the weight and height, looking for the mobility and functioning status. Then definitely there is the levels of bone profiles. The vitamin D is very important. We can repeat the DEXA scans in such patients on a treatment every at least 18 months to 24 months. It could be repeated. And you can as well do the bone markers as we were discussing within the investigations as monitoring the treatment as well.
Okay, thank you, Dr. Noura. I think we have further questions, but we are running out of time. It's time I'm sorry for the rest of the questions that we could not address. We will be now going to Dr. Jalal Nafash presentation. It's a sponsored symposium by Servier. So Dr. Jalal Nafash will present.
Good evening. I'm just not able to start the video for some reason by the host.
Can you hear me now, Dr. Jalal Nafash?
Yeah, I can hear you. Can you hear me?
Yes. So
Okay.
today, Dr. Jalal Nafash will present to us treatment priorities for patients with type 2 diabetes. Dr. Jalal Nafash is an endocrine consultant at Dubai Diabetes Center. The floor is yours, Dr. Jalal, and you can
Thank
start.
you. So, as you know, I work in Dubai Diabetes Center. It's part of Dubai Health Authority, and this is a disclaimer that usually I put in all the presentation I make. So this is mainly not related to any DHA policies. And I'm going to try to touch quick on a few aspects of diabetes. I'm not here, again, I'm invited by Servier, but this is not to say that sulfonylurea is the best thing or any of that, just to present the data. So always have to consider the fact that we have different options in treating diabetes. And we know as a fact it's becoming quite a bit of a prevalent disease, at least in the Middle East area, you're talking about 20% of the population. And you can see here on the graph that as we get older, the prevalence of diabetes gets higher. And you can see that in the 60s, it become about 25 to 30% of the population. Then you can start seeing that the prevalence goes down. And I think this is very likely because there is a higher risk of death, of course, in diabetic. And of course, that will make the prevalence of diabetes in the older population less. And the problem is, despite the fact it's becoming such a prevalent problem, is typically we don't have such a good control. It's somewhat similar to international numbers, but I mean, you have some data showing even down of 20% of the population only with diabetes that have a A1C below 7%. Now you have to remember that 7% it's the ADA goal. The ACE is 6.5, which is more realistic because at the end of the day, you try to be as normal as possible. And normal people have an A1C of 5.5%. And so if you have a patient who is newly diagnosed and you control them and they're doing very well and they're not getting hypoglycemia and their A1C is 5.5, I would maintain the same therapy because you're much more likely to be able to keep them in a good control if you do that. And I'll show you later the data. And the problem is, if you look at the NHANES, which is National Health and yeah.
Sorry for the interruption, but if you can please share your video with the audience.
It's not there?
Yeah, please. Just remove the arrow from the start video here.
I thought it's already sharing, sorry. I've been talking for a while without, okay. You have it now?
Yes.
Yeah, it's shared now.
Okay, sorry. So the problem with the National Health and Nutrition Examination study that this is mainly Northeast US, but mainly they look at data and get information about weight and blood pressure and waist and risks and so on. And of course, there was multiple times they did that, but you can see that the different collection data period that from 2003 to 2006, even if you compare it to 10 years later of 2011, 2014, despite the fact that we have a lot of new treatments, we're still not able to get a better control of the A1C. And so you can see over since the 1920s, we have very little invention in diabetes. And it's only the last period that we start having quite a few new therapies. And so that shows you that we're not implementing maybe the new therapies, but also we're maybe not utilizing very well, or maybe the patient is getting harder to control. But at the end of the day, the percentage of patients who are in a control of A1C still unchanged across those years. Now, one thing you need to remember is that, and we've seen that recently from the verified data, which is a combination of metformin and vildagliptin on newly diagnosed patients, that if you have a very good early intensive control, you're actually much more likely to maintain the control later. And that other analysis here we have, which contain 93,000 patients who were monotherapy on metformin or SU, and who were introduced intensification of therapy to achieve a A1C, and they call early intervention if the changes happen less than 12 months, intermediate between 12 to 24 months, and more than 24 months. And you can see that the earlier you are, the more likely to maintain the control. And so if you delay the intensification to 12 to 24 months, you're 22% less likely to maintain control. Now you have to remember that if you really need to follow the guidelines, if a patient uncontrolled for 3 months, you have to intensify and move on. You should not even wait the 13 months. But realistically, even if you look at the data from Europe, from Germany, from the US, usually the average delay in intensification with an average A1C of 8.1 typically run about 2 years to 2.5 years, and the delay to start insulin up to 6 years. So it is realistic to try to achieve early intensification, because this is more likely to maintain a good control and less likely to fail and need to be on insulin. Now, this is another cohort study, just to go back to the fact that we have to remember that we need to get a good glucose control. Yes, it is very important to reduce the cardiovascular risk, but we have to maintain the glucose control. This is actually data from a Swedish data baseline. Again, countries like Sweden have one of the best system where they have complete data healthcare system where you can track patient. And here they were looking at different criteria, including glucose, blood pressure, and smoking, and so on. And you can see that when you look at the benefit, at least in reduction in myocardial infarction and stroke, glucose seems to be in the headline. Now, again, we know that we need to get the glucose down. We know we should get it controlled very early. How can we compare the agent? And this is really kind of a meta-analysis. And mainly they were looking at 24 different anti-hyperglycemic agent and 229 randomized trials. So it's quite a bit of meta-analysis. And again, meta-analysis is a theory created, and at the end, it gives you strong evidence, but usually you would like to have a double-blinded study after it, which sometimes is very hard to do. But when you can look here, you can see that the glycoside here have a significant A1C reduction of 1%. GLP-1, of course, is superior, and then SGLT2 and DPP-4 and TZD shy of the glycoside in this meta-analysis. Now, ISA-DIAS study, it's a study on over 7,000 patients where a patient did receive the glycoside, and when you add the glycoside in this population, which were averaging A1C of 8.8%, you can see that if a patient is newly diagnosed or add to metformin or switch from a different SU or switch from DPP-4, there was a further significant reduction in the A1C between 1.6 to 2%. Now, the slide on the side on the right is usually what I like because it gives you an idea kind of what the estimated A1C reduction if you add glycoside. And so if you have a patient A1C between 7 to 8%, in this trial, there was a 1% reduction in the A1C. If you have an A1C between 9 to 10, you have 2.3% reduction. And if you have an A1C over 10, you have 3.8% reduction. So of course, as any other drug, you'll see more reduction in the A1C, the higher the A1C. But again, this is quite significant reduction if you compare it to other weaker agent. I mean, you can look at the data for an example. Again, I use a lot of DPP-4, but DPP-4 usually in the 9% range, you get about 1.3, 1.4% reduction in A1C. So in any agent, you may want to have an idea the expected reduction in the A1C. So if a patient come to you, for an example, and they already taken one agent and the A1C is 11, you're not going to choose to add just a single agent if you know that the expected reduction is not going to get them to target, because you're trying to get patient to target. And so such a patient, you may need to go directly to combination therapy, for an example. Now, the other part that you have to look at is not only that I can reduce the A1C, is the idea that I can maintain the glucose control. And we have very good example from the cardiovascular safety trial on the glycoside, the advanced trial. It's an old trial published many, many years ago, 2008. And in this trial, it was head-to-head compare intensive versus a control group. But what showed very clearly that they were able in the glycoside arm to maintain an A1C of 6.5% to 5 years after study, which is quite a good A1C, putting everything in consideration. You can remember that most of the diabetes trial, you can't see such a good A1C actually. And in another trial, trying to look retrospectively on how long did the patient maintain using sulfonylurea before the need to go to insulin. Now, this is the older data. So this is again published in 1996. So you have to remember those days were before the DPP-4 and SGLT2 and GLP-1 area. But again, just to show you the concept that in the population who were taking glucoside, they needed an average of 14.5 years to need to be on insulin versus 8 years on glibenclamide. So you are twice likely to fail the treatment if you're using glibenclamide, and you're more likely to have a higher A1C, where the average or mean A1C was 7.4 versus 6.8. And again, there are some in vitro data that show that there is less beta cell death, mainly using glucoside versus other sulfonylurea. So there is in the structure of the drug what it seems ability to not cause a failure of beta cell, as you can see in other sulfonylurea. Now, having a drug to lower the A1C is not a good drug unless I can prove safety. And you understand that always from an FDA perspective, usually even safety seems to be more important than even efficacy. And so here we're going to talk about some data to show the safety of this SU. And one is the Dia-Ramadan, which is again international real-world study looking in using glucoside during the fasting and the holy month of Ramadan. And so one of the issue, of course, that this study was trying to address is the fact that everybody worry about sulfonylurea and risk of hypoglycemia. Glucoside is well known to be, as it seems, less risk of hypoglycemia. The MR or modified release version allow progressive release of the drug. And so really trying to see, can I use this drug safely in Ramadan? Now, I'm going to show you later other data that already looked at glucoside. And so they're trying to enroll adult over 18 years old, treated with glucoside MR, and they were on it at least for 90 days before the start of the therapy. And of course, patients who are taking insulin were excluded because they're trying to avoid any other agent that can cause hypoglycemia to avoid confounding. patient with a significant abnormal A1C over 9%, because again, there is a safety concern, especially dehydration, patient with severe liver or renal disease, if they have any contraindication to glucoside, or if there is a history of severe hypoglycemia. So it's a regular design study, really to look at the safety of the drug. And of course, there was a visit 0, which is the inclusion visit, and then visit 1 at the end of the study. And there was usually 6 to 8 weeks pre-Ramadan, and then patient did fast during Ramadan, and then they had another 4 to 6 weeks post-Ramadan till they go to visit 1 at the end of the study. And there was about 1,214 patients from 64 sites, 9 countries. And the primary endpoint was the proportion of patients who have at least one symptomatic hypoglycemia or confirmed, this is a typo, or confirmed by concentration less equal to 3.9 millimole. And then they look at other points, which is the typical you see in diabetes trial, the A1C, the fasting glucose, the weight change, the patient was confirmed. But again, in this trial, again, the primary endpoint is symptomatic. So patient may not have a glucose monitor with him at that point, or did not check it, or confirmed by a glucose reading. Now, the average age was 54, the A1C was 7.5, established cardiovascular disease in 6% of the population, so they're healthier population. 35% have hypertension, 28% diagnosed as dyslipidemia. The statin were only 34%, and again, you have to remember this from different country. I can tell you most likely the population here are more statin treated, 14% on AS and ARB, and then 9 to 10% different blood pressure medication. 40% of the patient were taking only glucoside, and then 30% taking glucoside with 1 oral and another 30% with 2 or more oral. So it's kind of balanced on patient taking glucoside. Again, I think here in UAE, it tends to be more of the second group, which is 1 oral plus glucoside, usually metformin, or plus 2 oral. And what you can see here that the majority of patients were on the 60 milligram dose, few of them on the 90 and 120. And so 95% of the patients were treated on 60 milligram or more. And what we see here that in all across time, of course, there was less symptomatic, again, this is not confirmed, hypoglycemia of 0.2% in pre-Ramadan. During Ramadan, it was 2.2%, and post-Ramadan is 0.3%. And you'll say, well, this is higher rate. Well, you have to understand that you're here comparing one drug during pre-Ramadan and post-Ramadan. And again, there was no adjustment the way, I mean, for example, for myself, I always adjust the dose down usually when they go to the month of Ramadan and then allow them to go back on the dose. Now, when you look at comparing it to, for example, DPP4, which is the other trial which I'll show you, it'll give you a better idea. The second thing is in the post-follow-up, post-Ramadan, there was a 0.3% reduction in the A1C. Fasting glucose was improved by 9, and there was 0.5 kilogram weight loss. And to make it in perspective, keeping the glucoside throughout the month of Ramadan, there was 2.2%, which is not very high rate of symptomatic hypoglycemia, 1.6% of confirmed, there was 0.3% reduction in the A1C, and 0.5 kilogram weight loss. So it is very safe drug with such a low rate of hypoglycemia. And again, if we go back to another trial where it was open labeled and patients who were taking sulfonylurea were grouped into two groups, a group who maintained the sulfonylurea and group who was switched to sitagliptin. And they were looking also at the symptomatic hypoglycemia. And what you can see here clearly, that if you lump all the sulfonylurea in one group, you're going to have about 13% risk of hypoglycemia versus 6.7 in the sitagliptin. But if you split the sulfonylurea and you look each group by itself, you can see very clearly that the group with glibenclamide who fasted in Ramadan had such a high rate of 19.7%, glimepiride 12%, whereas the sitagliptin of 6.7 and glucoside 6.6. So the rate of hypoglycemia was very identical in the group of glucoside and sitagliptin who fasted in Ramadan. And one other study to just show you the safety in regard of hypoglycemia is the GUIDE study, which is again double-blinded randomized trials looking at adding glimepiride versus glucoside, and which showed very clearly that you can drop the A1C very similarly. In the glucoside, it dropped from 8.3 to 7. In the glimepiride, between 8.1 to 6.9, but there was statistical significant reduction in hypoglycemia using glucoside. And so you can see here the odd is 8.9% of the patient did develop hypoglycemia that is confirmed versus 3.7%, almost 70% less. And on top of that, weight is a very crucial part. So you need to have a good control of the glucose. You need to have sustainability of the control. I showed you the data. You need to have less hypoglycemia, which I showed you the data. And you prefer not to have much weight gain. And you can see that advanced trial, which is focused on using glucoside as main therapy for the intensive group, compare, for example, the VADT, which use glimepiride and rosiglitazone, or the UKPDS or the Accord. UKPDS, for example, use different sulfonylurea, are more likely to gain weight compared to the advanced trial. And so it allow you to get a good A1C reduction, no much significant risk of hypoglycemia, sustainability of effect, and on top of that, no weight gain. Now, the last thing that's, of course, or which is very important, is, of course, cardiovascular safety. And so, first of all, we have to remember Carolina study. And again, as you know, it's a cardiovascular outcome trial looking at safety of DPP-4 compare, in this case, to glimepiride, and DPP-4 with linagliptin, and they were looking at 3-point MACE. And the end of the trial showed very clearly that there is no difference whatsoever in the 3-point MACE, cardiovascular death, non-fatal MI, non-fatal stroke. So what that shows that even if I compare DPP-4, which as we know, it's cardiovascular neutral, to glimepiride, there is no difference whatsoever in cardiovascular event. And of course, you can extrapolate that to the glucoside, which shows very nice safety data. Now, if you try to collect the data over 167,000 patients, 18 studies, and collect the risk of cardiovascular safety, you can see that tend to see less of a risk. Now, again, doesn't mean that this drug reduces the risk, but very likely it does not increase the risk, at least for the glimepiride, and even preferably for the glucoside, for all-cause mortality and cardiovascular disease-related mortality versus, for example, the first-generation sulfonylurea, which shows that the curve to the right. So again, that speaks of the cardiovascular safety. And of course, nothing is more important than having a prospective randomized trial, and that's really what the advanced trial. So again, the advanced were diabetic patients who received glucoside and titrated, and then the investigator is allowed to add additional therapy as needed, then insulin, then multiple insulin therapy, versus using other sulfonylurea. And it showed very clearly that there is no increased risk of cardiovascular disease, and even the advanced ON trial, which is mainly a follow-up trial, the same as UKPDS follow-up, so mainly patient finished the trial, finished the randomization, and they were monitored to see if there's any change, and they continue to show that there is no sign whatsoever in increased events. The last part is renal protection. We know that now we get pretty excited about using SGLT2, and we should. I use a lot of SGLT2, and of course it needs to be considered in any patient with proteinuria as number one choice, of course. But here to present you a safety data from a renal outcome related to glucoside. And why is that important? Well, again, when a patient is already diagnosed with diabetes, they've already been diabetic for a few years, about 30% of them may have albuminuria. And at any point, you're going to have 30–40% of the patient may have albuminuria or significant macroalbuminuria or increased creatinine, all considered as a chronic kidney disease. And by looking at the advanced trial, which is, again, you have to remember, it's a huge study, 11,000 patients, you can look at the data, at least from the renal, and you can see that there was a 9% reduction in the new onset microalbuminuria, and there was an additional 30% reduction in new onset macroalbuminuria. There was 21% reduction in the progression of worsening of nephropathy. There was 65% reduction in need to go to end-stage renal disease and dialysis. And there was, of course, increase in the regression, which means a patient improved one stage in the proteinuria or 20% regression or decrease in the albuminuria. So it shows very nice safety or renal benefit, to say the least, in the advanced trial. Again, it's a randomized trial. And
Jalal Nafash,
yeah,
maybe you have 2 minutes more.
Yeah, okay. So if we look at, again, at the advanced and advanced on, you continue to see this benefit, despite the fact in the advanced on trial, there was no more active drug. And this is kind of a slide just to show you that even if I compare SGLT2 and, advanced data, again, in the advanced, there was 0.8% reduction in the A1C or difference. Here, there was a little bit less reduction. The big difference you see between SGLT2 and the glycoside is the proteinuria, but also you can see here 20% reduction versus about 40%. And the rest there you see quite a bit significant reduction in end-stage renal disease and a significant improvement in the regression. They are inferior, of course, to SGLT2, but they have a benefit. And again, it's a renal safe where you can use it in patients with renal insufficiency. So at the end, it is in all the guidelines. I'm sorry, I'm skipping. You always, if you have a patient with renal disease, cardiovascular disease, you have to follow the guidelines. But then other patients, you have choices, and one of the choices is sulfonylurea, in particular glycoside, as I showed you the safety, the reduction of hypoglycemia. Thank you.
Thank you, Dr. Jalal Nafash, for joining us today in our academic activity.
Thank
So
you.
that was an interesting presentation, well-structured talk, and well-illustrated graphs. So since we are running out of time, I have one question posted. I have a question posted to Dr. Jalal Nafash.
Okay.
We are running out of time, so I cannot read all the questions. Can SUs, can sulfonylureas lead to consume beta cells rapidly?
Well, okay, so the concern of beta cell exhaustion using sulfonylurea is a concern, especially with the older sulfonylurea. The data here I showed you from the advanced trial, there are in vitro data on glycoside, which does not seem to be the case in it. Of course, from all the agents for diabetes, the best agent that you have a beta cell preservation data is really TZD. I mean, if you look at it.
Okay, thank you, Dr. Jalal Nafash. For the rest of the questions that we could not address today, it will be posted on the ADS Institute website, and it will be addressed and replied back by the speakers. So by now we reach toward the end of the presentation. I would like to thank the participants. They are the backbone of our program. I would like also to thank the speakers who had an excellent presentation and great talks. I will also extend my thanks to the EDS Institute and Steering Committee and the President of the EDS, Dr. Fathia Al-Awadi, for facilitating this program for us. And again, I'm very grateful for Servier to sponsor our academic activity tonight. And definitely we will not forget the background, the MCI and the technical support group. Thank you for your efforts and support. We have an upcoming this activity, as I said in the beginning, it is in a CME accredited by Dubai Health Authority for 1.5. You will be receiving an email and a quiz. Kindly, you have to answer the quiz and fill the survey. Following that, in 7 days, you will be receiving your certificate. The webinar will be available on the ADS Institute website on demand, as well as on the EDS YouTube channel. We have an upcoming academic activities for the hypertension depth. 2 more sessions left, part 4. It will be held on 25th September. Part 5, hypertension diabetes therapeutic, will be on 9th of October. For our young leader forum program, this year we have 2 more workshops. One on 18th of November, it will be clinical pulse and the management of diabetes, starting from elderly to DKA and pump management. The third workshop in this year will be on 9th of December, diagnostic and therapeutic approaches of adrenal disease. I've enjoyed the talk and with you, and I have enjoyed the questions. Have a good night and fi aman Allah.